Okay, so let's get started talking about food chaining therapy. If you've taken any sessions with us before, you'll know that we feel very strongly about making sure that we know who we are treating. It is important that we completely understand the patients that are sitting in front of us and that we feel like we are helping them to the best of their abilities. And sometimes helping them means getting them to the specialist that they need to see. So in this first session, we're going to talk about identifying the roadblocks that might be standing in our therapy way. We're trying to make progress with them in treatment, and we're just hitting roadblocks and not making the progress that we anticipate. We're going to talk about how to make a treatment plan, and then we're going to talk about our therapy sessions. We feel so strongly about the 6 steps that have to happen prior to talking about food that we've created a worksheet for you, which is available when you signed up for this presentation. And we really encourage you to download this, print copies of it, actually use it as a working worksheet while you are seeing patients. I think this really helps patients and their families see what roadblocks stand in their way and how we're going to try to overcome those roadblocks. So the first thing you might do is you might take a feeding history and you're listening to the medical history, you're listening to their feeding difficulties, and you're going to go all the way back to infancy, no matter what age your patient is. And things that you are concerned might have an impact on the feeding difficulties. That's where you can list some of the medical issues. If you feel like they have recurrent pneumonia, that's definitely something that's of concern. Put that in there. If they were premature, we're going to write that down because we know prematurity doesn't end. If they have reflux that is treated or untreated, but parents are describing symptoms of reflux, we might put that on one of the lines here. And we're just going to be thinking about anything that might be interfering with feeding. And then over on the intervention and referral side, we're going to talk about how we're going to address that. Whether it's a referral to somebody who can help us further pinpoint what might be going on, or maybe it's something that we're going to try to make an impact on through our feeding sessions. Same thing about nutrition. As you're taking that history and listening to parents tell you what the problem is, we are going to write down things like excessive liquid intake. We might put down that, when they're going through like a food recall, that it's eliminating fruits and vegetables. Maybe they don't have any meat or any protein source. So we can list those things. It also might be that they're on an excessive amount of a caloric supplement, and we feel like the amount of a caloric supplement they're taking might be interfering with their ability for oral intake. Anything that you find as a problem when parents are describing, put it down here, and so we can really think about it. This helps me. When we develop this, we put it in practice with our therapists and encourage people to use it with their parents. And overwhelmingly, this really helps both the therapist and the parent see where we're headed and what we're addressing. So we've talked a lot about the first year of life, that maybe they were pretty colicky as an infant and they didn't latch well and they really had trouble finding a bottle that worked, and they were on multiple formulas, and then they didn't gain weight enough and they had difficulty going to bottle, and that each step along the way they just really struggled to that next level of feeding. When we know that and hear that as a description, we know that that is not a behavioral issue. Many times people want to treat feeding problems as behavioral, when in fact, when the feeding problem began in infancy, it's not a behavioral feeding issue. Not to say that behaviors don't arise, but that's not the root of the cause. So we want to think back and we want to tell parents this, because a lot of parents have been told things like, well, I'll take them home and I can get them to eat. And, in my day, I can, they ate what we served and things like that. But it's good to say this isn't to tell parents, and I tell every parent that walks in the door, this is nothing that you did that caused this. These are the struggles that this child is having, and here's where we think it began. And do you see that these, something here maybe got off track because of either a medical issue or some sort of digestive issue or a skill level issue that just took a wrong turn for feeding, and we're going to help them correct that. The core disorder needs to be identified and explained to parents so that they understand that. There's a lot of parents who come into our clinic and they cry and they feel very guilty and they can't believe that they've gotten here with their child, and meal times are so stressful. And I think that we really need to tell them that we're going to help them get back to some of those foundation feeding skills so that we have a firm foundation to be able to build the next skill or those next feeding textures on. So Easter rolls around and he's able to lick the sugar from the Peeps and was successful with that. And he was interested in marshmallows, but he really wasn't ready for marshmallows yet because he got a little bit nervous with this food. So I'm going to let you watch this little video, but gosh, just being able to be brave enough and want to do it was awesome. But I think we needed to break that step down a little bit for him, and I didn't want him to take any steps backwards because of any negative responses. But let me let you watch this little clip of his reaction with a marshmallow.
Promise me. Now you got to kind of swallow it. Remember what we said. Chew it, swallow. Good job. Yep, you got to swallow, swallow. Good job. Oh, Bobby, you're doing good. Chew it. Oh, Bobby, good job. Good job. Oh my gosh, you chewed it and swallowed it. Give me 5. Woo, that was awesome.
Okay, so you could see that video and you could think two things. Oh my goodness, why does he have a marshmallow? Or you can think, oh my goodness, he was brave enough to put that solid piece of food in his mouth and attempt to chew it and attempt to swallow it. He's totally not ready yet from an oral motor standpoint, but you can see the walls of anxiety starting to break down. He's pretty proud of himself, even despite the therapist in me is worried about the gagging and the other things. But how far this little guy has come is just absolutely amazing that he was willing to even participate in that. So instead of something like a marshmallow, we really got started working on the crumbs of a meltable solid. So we were crushing Ritz crackers. We were crushing Oreos because his grandpa liked to eat Oreos and he wanted to be able to eat Oreos with his grandpa. So we crushed those basically to dust. And since he was able to lick the sugary substance of the candy and the Peeps and all of those things, I thought he was probably ready for the meltable solid crumbs so that we could maybe get something where he was actually starting to work on the chewing and the swallowing without eliciting the gagging and the need for the water. Now, don't get me wrong, he was extremely nervous about this and he would tell me that he couldn't do it. And things like that. But we started very small. And what I did find with Waylon is if I told him what the expectation was, and I strongly encouraged him to participate in it, and we always played a game. We always did something to try to distract a little bit away from the activity because he would get really nervous. But if we participated in it and then I would distract him by playing Connect 4 launch, or if we were playing a game, he was immediately spinning the spinner after taking his bite. He was able to get through the activity a little bit better. So we did meltable solid crumbs on the Duo spoon as well. So just like I was rubbing the Duo spoon on in flavor to give, a little bit for him to chew, now I was putting a few meltable solid crumbs on there and encouraging him to lateralize and chew on the spoon. So here is a little video that I'm going to show you of him chewing an Oreo.
the whole thing.
So they're prompting him to chew. You can see there's no gagging. And we progressed from the crumbs to actually taking a small piece and chewing it. All that work with a duo spoon over on the biting surfaces got us to the point where now he was accepting some small pieces.
So why is it important to chain? Because you're stacking the deck in your favor. You're offering highly likely foods to be accepted. Successful food exploration reduces that fear and it adds variety. The child has a success. The parent sees that. The parent is impressed. The parent is less stressful. This is working. Everybody just relaxes into it. So we did all the cheese-flavored crackers and Ritz Bits, and I was going for cheese and hopefully into peanut butter. Ritz Bits and peanut butter in the future, and cheese could go lots of places. And I was hoping to reach a cheese quesadilla, toasted cheese, things that he could eat easily, or thin crust cheese pizza off of those pizza crusts. Later in the program, it would depend on his ratings and how he reacted. But these are great possibility foods. Think of all the ways cheese can be expanded. Think about expanding those crusts. Think about expanding that peanut butter. So yes, you can chain cookies. And we did a variety of flavors and types of cookies. And Stephen was able to shop with his mom, pick out some cookies he wanted to try. Low risk, highly likely to be accepted. They tried shortbread cookies and he liked them. He liked snickerdoodles and they crumbed really easily. And we started working cinnamon, brown sugar. And then we knew we could try maybe a lemon shortbread for a new taste because he didn't have. He had lemonade. Maybe he would like the lemon shortbread. And so we talked to him about, well, you like lemonade. Look, have you ever had a lemon cookie? And then much later, where could the crust be? Down the road, quiche or pot pie? Possibly. It's happened with some kids. So when he first came in, he's 7 months old. With cares we were watching, with touch to his body, we saw breathing changes, we saw color changes and signs of distress. Hated the fluorescent lights. We brought down stimulation in the room. He had very increased tone in his upper extremities and significant weakness in his core. He had that very weak, ineffective kind of open mouth secretion swallow and a lot of pooling. You could hear it in his breathing. And he was getting breast milk. Mom was pumping and administering it by the NG. Now we noted visible laryngopharyngeal reflux when he was reclined for diaper change, color change, and gastric aspiration risks were considered high. And we saw that high-grade reflux when we did his feast study as well. I mean, you could just see it fill the back of his mouth. His weight was appropriate at that time at 7 months. So I told Mom, it's like that song from The King and I, Getting to Know You. I said, I need to get to know Adam. The local therapist was trying some oral motor therapy and putting her fingers in his mouth, and he was vomiting. And they were trying taste of thickened breast milk, but there was no progress. And what I want you to think about, okay, open your mouth slightly and just dry swallow. There's no power. He has dysphagia. He's having all these problems. Is his swallow going to be safe for thickened liquid? His dysphagia is so severe, he needs NG. He's gaining weight on NG. It's important for us to think about what we're doing.